Our topic for this session is venous thromboembolism. The learning outcomes are as follows. So first, we will define and classify venous thromboembolism, discuss the pathophysiology, discuss the diagnosis, treatment, and prevention. Venous thromboembolism is defined as a vascular disease encompassing both deep vein thrombosis and pulmonary embolism. In the United States, approximately 100,000 to 180,000 deaths come from pulmonary embolism. It is the most common preventable cause of death among hospitalized patients. So the pathophysiology behind venous thromboembolism is the Virchow's triad of inflammation, hypercoagulability, and endothelial injury. So in this triad, there will be recruitment of activated platelets, the release of microparticles containing pro-inflammatory mediators, binding of neutrophils, and formation of web-like extracellular networks. And lastly would be your stimulation of platelet aggregation and thrombin generation. The two most common autosomal dominant genetic mutation are factor V Leiden, okay, which is resistance to endogenous anticoagulant activated protein C, and prothrombin gene, okay, which increases plasma prothrombin concentration. The rare genetic mutations are deficiencies of antithrombin, protein C, and protein S. Antiphospholipid antibody syndrome, or the APAS, is the most common acquired cause of thrombophilia. So this slide, okay, will tell you the prothrombotic states, okay, the other predisposing factors for the triad. So for venostasis, obesity, and long-haul air travel, okay, are factors. For endothelial injury, so cigarette smoking, systemic arterial hypertension, prolonged surgery, trauma, and prolonged exposure to air pollution predisposes one to develop endothelial injury. And hypercoagulable state, okay, the most common of which is cancer or malignancy. So others are COPD, history of chronic kidney disease, history of blood transfusion, patients who are on oral contraceptives. Pregnancy itself is a hypercoagulable state, and women on postmenopausal hormonal replacement. So during embolization, okay, the deep venous thrombi detach from site of formation, okay, then embolize to the vena cava, going to the right atrium and right ventricle, then eventually lodge into the pulmonary arterial circulation, causing acute pulmonary embolism. On physiology, okay, the most common gas exchange abnormalities are arterial hypoxemia, where there is decreased arterial oxygen levels and an increased alveolar arterial oxygen tension gradient, okay, which represents inefficiency of oxygen transfer across the lungs. So other gas exchange abnormalities are, so it may increase your anatomic dead space, okay. It may increase the physiologic dead space, so ventilation to gas exchange units exceeds venous blood flow through the pulmonary capillaries. Increased pulmonary vascular resistance, okay, may also result because of the vascular obstruction, as well as impaired gas exchange. Okay, this may be secondary to an increased alveolar dead space, a ventilation perfusion mismatch, right to left shunting, and impaired diffusion. So others are alveolar hyperventilation, increased airway resistance secondary to bronchoconstriction, and a decreased pulmonary compliance, at a later stage because of lung edema, hemorrhage, and probably loss of surfactant. Now let's discuss pulmonary hypertension, RV dysfunction, and RV microinfarction in VTE. Okay, when there's pulmonary artery obstruction, okay, this will increase your pulmonary artery pressure, the PAP, and your pulmonary vascular resistance because of that obstruction. Okay, hence, okay, there will be an increased tension in the right ventricle wall. Okay, and this will cause right ventricular dilatation and dysfunction. Okay, so compressing your right coronary artery, okay, probably causing ischemia and microinfarction. The interventricular septum compresses the left ventricle, and the diastolic left ventricular dysfunction reduces your left ventricle distensibility and impairing the left ventricle filling. Okay, so in effect, okay, there will be fall in your cardiac output and blood pressure. Okay, so and then eventually, okay, this will lead to circulatory collapse and death. Okay, so pulmonary embolism is classified as to massive PE, submassive PE, and low risk PE. So when you say massive PE, it's around 5 to 10%. There is extensive thrombosis affecting at least half of the pulmonary vasculature and may present with difficulty of breathing, hypotension, syncope, and cyanosis. Okay, whereas submassive PE, okay, around 20 to 25%, there is RV dysfunction despite a normal systemic blood pressure. Okay. And low risk pulmonary embolism, that's 70 to 75%, has good prognosis. On the other hand, deep vein thrombosis is classified as to lower extremity or upper extremity DVT. So when you say lower extremity DVT, it begins in the calf, propagates proximally to the popliteal, femoral, and iliac veins. And it is 10 times more common than upper extremity DVT. For upper extremity DVT, it is usually precipitated by placement of pacemakers, internal cardiac defibrillators, and central venous catheters. We also have that superficial venous thrombosis. So it presents with erythema, tenderness, and a palpable cord. Okay, at risk for extension into the deep venous thrombosis. So it increases the risk for deep venous system. Now, how do we diagnose? So pulmonary embolism is known as the great masquerader, whereas the symptoms and signs are non-specific. Okay, so unexplained breathlessness is the most common symptom. Okay, and in some cases of occult pulmonary embolism, okay, there is no clinical improvement despite standard treatment of concomitant illness. For DVT, the most common symptom is a cramp in the lower calf. Okay, and it often persists and intensifies over several days. So here is a clinical risk scoring. So a clinical decision rules on how to classify if a patient has a high clinical likelihood of developing PE or a low clinical likelihood. So for DVT, okay, here are the clinical variable. So active cancer, paralysis, so immobility. Okay, so bedridden for more than 10 days or underwent a major surgery. So tenderness along distribution of deep veins. So these are the clinical variables. So high clinical likelihood of PE. Okay, here are the clinical variables. So signs and symptoms of DVT, alternative diagnosis less likely, a heart rate more than 100, immobilization, prior pulmonary embolism or DVT, hemoptysis, and cancer. Okay, so there is high clinical likelihood of pulmonary embolism if the point score exceeds 4. So these are the differential diagnosis, okay, for DVT and PE. So for deep vein thrombosis, it may just be a ruptured Baker cyst, cellulitis, or a post-phlebitic syndrome or venous insufficiency. Okay, for pulmonary embolism, it may be just a case of pneumonia, asthma, chronic obstructive pulmonary disease, congestive heart failure, pericarditis, pleurisy, rib fracture or pneumothorax, ACS, and anxiety. Okay. That's why you have to do imaging studies. Okay. So here is an algorithm for diagnostic imaging for both DVT or PE. So first step, okay, when you suspect a patient having DVT or pulmonary embolism is to assess the clinical likelihood. So the table that we projected earlier. Okay, so if there's a high clinical likelihood, okay, for DVT, is it low? Okay, you request for D-dimer. So it is normal, then there's no DVT. If it's high, proceed to imaging test. Okay. If it's not low, okay, then immediately proceed to the imaging test. So for pulmonary embolism, you assess the clinical likelihood. If it's high, then immediately proceed to the imaging test needed. Okay. And if it's not high, okay, you may request for D-dimer. Okay. So if it's normal, then there's no pulmonary embolism. If it's high, okay, then proceed with the imaging test. Quantitative D-dimer or enzyme-linked immunosorbent assay, ELISA, okay, is the one we used. Okay, so rises or increases in the presence of DVT or pulmonary embolism, okay, because of the breakdown of fibrin by plasmin. So D-dimer increases. Okay, the sensitivity is more than 80% for deep vein thrombosis, whereas in pulmonary embolism, it's more than 95%. So it is sensitive. However, a normal D-dimer, okay, is a useful rule-out test. Okay, but it is not specific, okay, since it may give a false positive result in patients who suffer from myocardial infarction, pneumonia, sepsis, cancer, post-operative patients, as well as pregnant patients. How about cardiac biomarkers? So serum troponin increases due to right ventricular microinfarction. Okay. Whereas NT-pro brain natriuretic peptide or BNP may be increased, okay, because it is released due to myocardial stretch. So these cardiac biomarkers are indirectly related. Okay. So most common abnormality on ECG is T-wave inversion in leads V1 to V4. Okay. Other findings in ECG are sinus tachycardia, S1Q3 T3 sign, meaning there is an S wave in lead 1, a Q wave in lead 3, and an inverted T wave in lead 3. So this one is specific but insensitive. So echocardiography. Okay, it is not a reliable diagnostic imaging tool for acute pulmonary embolism, since most patients with pulmonary embolism have normal echocardiogram, especially if it's acute. Okay, it is useful for conditions that may mimic Okay, pulmonary embolism such as acute MI, pericardial tamponade, and aortic dissection. A finding in echocardiography is the McConnell sign, okay, where there is hypokinesis of your right ventricular free wall with normal or hyperkinetic motion of the right ventricular apex. So that's McConnell sign, echocardiography findings. Okay. How about venous ultrasound? Okay. This is a diagnostic imaging that we use for deep vein thrombosis. So the primary criterion for deep vein thrombosis is loss of vein compressibility. This is caused by passive distension of the acute thrombus. So here you can directly visualize the thrombus since venous flow dynamic by Doppler imaging. It has virtually replaced contrast phlebography for diagnosis of DVT. Okay, so this one is your primary imaging of choice for DVT. How about findings on chest radiograph? Okay, it may be normal or near normal. Okay, or you may see signs such as Westermarck sign, so which is a focal oligemia or avascularity. Next would be Hampton's hump or a peripheral wedge-shaped density above the diaphragm. And Pallas sign or an enlarged right descending pulmonary artery. Okay, so Westermarck's, Hampton's hump, and Pallas sign. So this image, okay, represents a wedge-shaped density. So that's Hampton's hump. Okay, this one is Westermarck's sign. So an area of focal oligemia. Compare it this area with the other side. Okay, so there is an area of avascularity. What about on chest CT scan? Okay, so chest CT with IV contrast is the principal imaging test for diagnosis of pulmonary embolism. So the findings would be intraluminal filling defects, okay, noted on chest CT. So sixth order branches can be visualized with resolution superior to conventional pulmonary angiography and also provides an excellent four-chamber view of the heart. Okay, it may establish alternative diagnosis not apparent on chest X-ray. So ventilation perfusion scan is another imaging study. So it is a second-line diagnostic test for pulmonary embolism. Okay, it is used for patients who cannot tolerate IV contrast. So perfusion scan defect indicates absent or decreased blood flow. And abnormal ventilation scans indicate abnormal non-ventilated lung. So it may give a false positive result in cases of asthma, COPD, pneumonia, and pulmonary tuberculosis. So a high probability scan is where there is two or more segmental perfusion defects in the presence of normal ventilation, okay, and has 90% certainty of pulmonary embolism. So PE is very unlikely with normal or near normal scan. So most of the time, there should be abnormality. Okay, so most patients have non-diagnostic scans, so low probability or intermediate probability. So as many as 40% of patients with high clinical suspicion for PE but low probability scans have PE on angiography. So here's an example of lung perfusion scanning. Okay. So the pointed arrow points to the area of affected area. Okay, so non-ventilated area. How about MRI or magnetic resonance imaging? So MR venography with gadolinium contrast is an excellent modality to diagnose deep vein thrombosis. Okay, so it is used when ultrasound is equivocal. Okay. Whereas MR pulmonary angiography may detect large proximal pulmonary embolism. However, it is not reliable for smaller segmental and subsegmental pulmonary embolism. So pulmonary angiography is an invasive procedure. It is catheter-based diagnostic testing and is usually reserved for technically unsatisfactory chest CT. So meaning the results in the chest CT is equivocal. So if interventional procedure is planned, okay, catheter-directed thrombolysis is usually done. So the definitive diagnosis for pulmonary embolism is a visualization of the intraluminal filling defect in more than one projection. So that's definitive diagnosis for pulmonary embolism. So aside from the definitive signs, okay, we have secondary signs of PE. So you can see from the result if there's abrupt occlusion or cut off of vessels, segmental oligemia or avascularity, okay, a prolonged arterial phase with slow filling, and tortuous or tapering peripheral vessels, all of which are suggestive of pulmonary embolism. So here's an integrated diagnostic approach, okay, for DVT and PE diagnosis. Okay, so for DVT, so you do an imaging test, okay, a venous ultrasound. So if it's diagnostic, you stop there. So you already have a diagnosis. If it's non-diagnostic, your options are magnetic resonance imaging, chest CT scan, and a phlebography. For pulmonary embolism imaging test, okay, your imaging test of choice is chest CT with IV contrast. If it's diagnostic of PE, then you stop and initiate treatment. If it's non-diagnostic, unavailable, or unsafe, perform lung scan. Okay, so if it's diagnostic, you stop and initiate treatment. If non-diagnostic, perform venous ultrasound. Okay, so if it's negative, you further do MR, transesophageal echo, or invasive pulmonary angiography. But if it's positive, you treat immediately for pulmonary embolism. So after diagnosis, we treat. Okay. So the primary therapy or treatment for deep vein thrombosis is clot dissolution, okay, with pharmacomechanical therapy. So it includes a low-dose catheter-directed thrombolysis. Okay, so this therapy is reserved for patients with extensive femoral, iliofemoral, or upper extremity DVT. Secondary prevention is anticoagulation, okay, or placement of inferior vena cava filter, and also applying graduated compression stockings. So this is to lessen the severity of a post-thrombotic syndrome of legs, so for 2 years after deep vein thrombosis. So risk stratification for pulmonary embolism. So high risk of adverse outcome. So those who have hemodynamic instability. So if there's an episode of hypotension, tachypnea, tachycardia, all right. RV dysfunction on echocardiography. So findings of RV dysfunction. Finding of RV enlargement on chest CT scan. And elevated troponin levels. So these are high risk of adverse outcome. So here's an algorithm for pulmonary embolism management. So you have to risk stratify. So you classify it as normotension plus normal right ventricle, normotension plus right ventricular hypokinesis, and a patient who has hypotension right away or hemodynamic instability. So for normotension plus normal right ventricle, you may initiate secondary prevention. Okay, you may give anticoagulation alone or placing an IVC filter if necessary. For normotension plus right ventricular hypokinesis, you individualize therapy. So individual basis. For hypotension or hemodynamic instability, you initiate primary therapy, so clot dissolution. So this can be done by anticoagulation plus thrombolysis or embolectomy. So anticoagulation as a form of secondary prevention, okay, is the foundation for successful treatment of DVT and pulmonary embolism. So you have three options. So the conventional strategy where you start first with parenteral therapy, okay, then bridging it afterwards to warfarin or oral. Parenteral therapy bridged to a novel oral anticoagulants or NOACs. So the newer medicine, so the bigatran or edoxaban. Or oral anticoagulation with rivaroxaban or apixaban loading dose, followed by a maintenance dose. So here is a table, okay, of the different types of anticoagulation of venous thromboembolism. So you have here immediate anticoagulation. Okay, here are your options. You can give unfractionated heparin, enoxaparin, dalteparin, tinzaparin, fundaparin, okay, direct thrombin inhibitors, rivaroxaban, and apixaban. So whenever you want to bridge it with an oral or warfarin, okay, anticoagulation, so it requires 5 to 10 days of administration to achieve effectiveness as monotherapy. Okay, and the usual start dose is at 5 milligrams with a target INR of between 2 to 3. Okay, so you have to continue parenteral anticoagulation with a minimum of 5 days and until two sequential INR values, at least 1 day apart, achieve the target INR range. Okay, and the NOACs for extended duration anticoagulants following initial parenteral anticoagulation. So you have edoxaban and dabigatran. So heparin-based parenteral anticoagulants, okay, first would be unfractionated heparin. Okay. During your pharmacology, you are introduced to UFH. Okay. It binds to and accelerates the activity of antithrombin. Okay. Those to achieve target PTT of 60 to 80 seconds. Okay. So initially, you give a bolus of 80 units per kilo with an initial infusion rate of 18 units per kilo per hour. It has a short life. Okay, so you have to have an R to R control of intensity of anticoagulation. Next would be low molecular weight heparins or LOMO. So these are fragments of heparin which have greater bioavailability and more predictable dose response and a longer half-life. Okay, so there is no monitoring nor dose adjustment unless markedly obese or with chronic kidney disease. Third option is fundaparin. It is an anti-10A pentasaccharide. It is weight-based, given once daily via subcutaneous injection with no monitoring required and does not cause heparin-induced thrombocytopenia. So it is a good option. So warfarin is a vitamin K antagonist and prevents carboxylation activation of factors 2, 7, 9, and 10. And the full effect requires 5 days. Okay. Early, okay, it has early procoagulant effect nullified by overlapping unfractionated heparin, low molecular weight heparin, fundaparinol, or parenteral direct thrombin inhibitors for 5 days. So whichever is your choice. NOACs or novel oral anticoagulants is administered with fixed dose. So if it is effective within hours of ingestion with no monitoring required, with few drug-drug or drug-food interactions. So example are factor 10A inhibitors, so rivaroxaban, apixaban, edoxaban, and direct thrombin inhibitor, which is dabigatran. So what are the common complication and how do we manage these complications? So hemorrhage is the most serious adverse effect of anticoagulation. You can have unfractionated heparin or low molecular weight heparin induced bleeding. So for life-threatening cases, you can give protamine sulfate as the antidote. Okay. Warfarin-induced bleeding. Okay. In warfarin-induced bleeding, you may give prothrombin complex concentrate for major bleeding, fresh frozen plasma or intravenous vitamin K for serious but non-life-threatening bleeding, or oral vitamin K for minor bleeding or excessively high INR without bleeding. Okay. So, how long do we anticoagulate? So, 3 months for an isolated upper extremity or calf DVT provoked by surgery, trauma, estrogen, indwelling central venous catheter or pacemaker. 3 to 6 months for initial episode of provoked proximal leg DVT, and indefinite duration for patients with cancer, venous thromboembolism, unless rendered cancer-free, or for unprovoked idiopathic VTE and APAS. For IVC filter, okay, it is indicated for patients who have active bleeding that precludes anticoagulation and those with recurrent VTE despite intensive anticoagulation. Other indications are prevention of recurrent PE and prophylaxis of extremely high-risk patients. For massive PE, okay, we can give saline infusion. Okay, so for massive pulmonary embolism with hypotension, we can initially give fluid infusion with up to 500 ml normal saline. Okay. But be careful since excessive fluid administration may exacerbate RV wall stress, RV ischemia, and worsens your left ventricular compliance and feeding. Inotropic agents. Okay, so you can start your patient with dopamine and dobutamine, okay, which are first-line inotropic agents for pulmonary embolism-related shock. Okay. Normally, you maintain a low threshold for initiating pressors. So other available agents are norepinephrine, vasopressin, or phenylephrine. Fibrinolysis in massive PE, okay, may reverse right heart failure and may result in lower death and recurrent PE. So how? So it dissolves much of the obstructing pulmonary arterial thrombus. It may prevent the release of serotonin and neurohormonal factors that exacerbate pulmonary hypertension. And of course, it lyses much of the thrombus in the pelvic or leg veins. So the preferred is 100 milligrams of recombinant tissue plasminogen activator. Infusion, okay, you give it over 2 hours. So infusion over 2 hours. So the contraindication for doing fibrinolysis is if the patient has intracranial disease, underwent a recent surgery, and trauma. Pharmacomechanical catheter-directed therapy combines physical fragmentation or pulverization of thrombus with catheter-directed low-dose thrombolysis. Okay? And pulmonary embolectomy, okay, the same as surgical, offers more rapid referral and improved surgical technique, okay, which resulted in higher survival rates. So now we discuss prevention. So how do we prevent venous thromboembolism? So prevention of DVT and PE is of paramount importance. VTE is difficult to detect and poses profound medical and economic burden. So the most common forms of in-hospital prophylaxis are, so you can give low-dose unfractionated heparin and low molecular weight heparin. So prophylaxis protocols are readily available in healthcare institution. This is to increase utilization of preventive measures. So here's a table of prevention of VTE. Okay, in the hospital setting among high-risk patients. So for high-risk non-orthopedic surgery, okay, you may give heparin, enoxaparin, and dalteparin. Okay, so for cancer surgery, you may give enoxaparin. For major orthopedic surgery, you have many choices. For medically ill patients, especially if immobilized with a history of VTE, okay, your options are unfractionated heparin, enoxaparin, dalteparin, and fundaparinum. And whenever anticoagulation is contraindicated, okay, you may start intermittent pneumatic compression devices. Okay, so that's it for venous thromboembolism. Thank you.